start the glenohumeral joint and then finish it next week. So let's kind of see how we do time-wise. So for this lecture, we're going to do just a little bit of a review for your bones, your joints, your muscles, and then just a little bit of application for these concepts. So here are some of your objectives for this lecture: to review shoulder girdle terminology, your key bony landmarks and associated soft tissue structures, discuss the joints of the shoulder girdle, review your osteokinetic motions and your planes and axes again. Hopefully that is easy by now. Talk about scapulohumeral rhythm and its importance to overhead movement. Understand and apply the arthrokinematics of the sternoclavicular joint. So again, last week was concepts, now we're going to start applying them to the individual joints. Okay? Your muscles, origin, insertion, nerve, and action. Okay? And then talk about this slightly in response to, or in regard to posturing. Okay, we'll go into posture much more deeply next semester, but I just want to start getting you guys thinking about it a little bit. Okay? So first, I just want to make sure we are clear on terminology when it comes to the shoulder and the scapula. Okay? So when we talk about the shoulder girdle, this is going to be the proximal portion of your appendicular skeleton. Okay? So it functions as the connection between that axial skeleton and the upper extremity. Okay? So the terms shoulder girdle and shoulder complex are synonymous. Okay? They mean the same thing. Okay? So if we are talking about your shoulder girdle, this is going to involve your scapula, the clavicle, and the sternum. Okay? Meaning, when it comes to your joints, this is going to talk about your sternoclavicular. Are you okay back there?
Yep.
Okay.
My heart palpitations. It's okay.
Okay. All right. Please no passing out. All right. Sternoclavicular joint. I completely just lost my train of thought. Sternoclavicular joint, acromioclavicular joint, and your scapulothoracic joints. Okay. So those are the three that are going to be involved in your shoulder complex. If we are talking about your shoulder in isolation, just the shoulder, okay, that is going to be your glenohumeral joint. Okay, that only involves the scapula and the humerus. Okay, just that one articulation between your scapula and your humerus. Okay, so if you're talking about the sternoclavicular joint, that has nothing to do with your glenohumeral joint. So make sure you're able to understand that differentiation. Okay, so brief review for your bony anatomy. Okay, we're going to practice palpating a lot of these structures in lab today, so that again will help to reinforce this. Of course, I still want you guys to review your bony anatomy from Bio 150, but we are not going to go as in depth with the bones as we did in Bio 150. Okay, it's like a lot of the little notches and things. I'm not as worried about that. We're going to focus more on the structures that we can actually palpate along with your muscular attachments. Okay, so if we can't palpate it, and if it's not somewhere there's an origin or an insertion, I'm not as worried about it as we move forward. Okay, so in here, this is much more application of the bony landmarks versus just you guys need to learn 8 million different landmarks on these bones. Does that make sense? Mm-hmm. Okay, so again, hopefully this is a review, but just to point out your important structures for the scapula. Okay, is this an anterior or posterior view of the scapula?
Anterior.
Okay, what about this one? Posterior. Exactly. So we have anterior view, we have posterior view. Looking at the anterior view, you want to know your borders. Okay, so you have your superior angle, which is the very top tip of the scapula, and your inferior angle, which is going to be the bottom. You have your medial border and your lateral border. Okay, this whole divot in the middle is going to be your subscapular fossa. What muscle originates there? Subscapularis. Okay? Those terms go together, so that should be an easy one to remember. This right here is going to be your coracoid process. You can see the acromion here. You can also see it on the posterior view. Okay? That's your main highlights for the anterior view of the scapula. On the posterior view, we have your supraspinous fossa. What originates there? Supraspinatus. And then we have the infraspinous fossa. What muscle is there? Infraspinatus, good. So those are going to be divided by your scapular spine, or the spine of the scapula. Okay? That's going to come over and turn into your acromion more laterally. Okay? All right, any questions there? All right, so again, make sure you review those and you're comfortable with identifying them. Okay? Let's see your hands. Scapular elevation, depression, protraction, retraction, upward rotation, downward rotation. Good. Any questions? You guys got it. Okay, so with your scapular motions, based on what you guys did, we have both linear motion and angular motion that occurs at the scapula. Okay? So your elevation, depression, and your protraction, retraction are actually linear motions, okay? Versus your upward and downward rotation are considered angular motions, okay? Because of the triangular-like shape of the scapula, when the inferior angle moves in one direction, the superior angle is going to move in the opposing direction. Okay? So when you name these motions, you are naming them based on what the inferior angle is doing. Okay, so if this is my scapula, this is my superior angle, this is my inferior angle. When I go into upward rotation, I'm naming it by what my inferior angle is doing. Okay, does that make sense? Okay. All right, so when we were reviewing the planes and the axes, I got a lot of questions on the scapula, okay? So I told you at that time not to worry about it for now, and now we're gonna dive a little bit deeper into this, okay? So this is going to be different because you have the rounded thoracic cage, okay? So since it's rounded, your scapula can't truly sit in the frontal plane, okay? So its orientation is actually going to be 30 degrees from the frontal plane. So you can see that in this diagram here. Okay, so this blue line is indicating the plane of the scapula, or the scapular plane. Okay, again, your scapular plane is going to sit 30 degrees forward of the frontal plane. Okay, the term for motion in this plane is called scaption. Okay, so if I'm moving my arm or my shoulder 30 degrees forward of the frontal plane, it kind of comes out at an angle like this. This is scaption. Okay. All right, so your upward and downward rotation of the scapula, we're here and I'm tilting like this. What motion is that like at the glenohumeral joint? What? Abduction and adduction. So what plane and what axis do you think that's going to occur in? Frontal plane, sagittal axis. Okay, so technically speaking, your scapular upward and downward rotation are going to occur in a frontal plane. Okay, and this is actually going to occur around a horizontal axis. Okay, because of that rounded thoracic cage. Okay, scapular tilt is this forward and backward motion of the scapula. Okay, that is going to occur. Sorry.
Yes, I have a question because in the book I think so it's a mistake because in the scapular upward rotation and downward rotation and scapular tilt, all of them says that are horizontal axis. It doesn't make sense to me. It says for upward rotation downward, so horizontal axis, that must be sagittal axis, and scapular tilt, that is sagittal plane, and frontal axis is horizontal axis.
Okay, just disregard this for now. Let me look back in the book and make sure everything is correct and everybody's on the same page, and I'll readdress this either later in the week or when we're back together next week. Okay? Okay, but in your book, it does say so I was going to say scapular tilt technically occurs in the sagittal plane around the horizontal axis. That's what's in your book, correct? Okay. All right, so that's what we're going to go with for now, and then, like I said, I'll readdress this concept.
So what is the horizontal axis?
So horizontal is the same as transverse.
Okay.
Where all the rotation is.
Yeah.
All your
I thought that
rotations
was always a vertical axis.
But you have this exception because we're not truly sitting in the same planes as every other osteokinetic motion. Since you have that 30 degree of you're sitting in the scapular plane, which is 30 degrees forward of the frontal point. So this is an exception to your typical rules.
Okay.
Okay, so so these are technically going to be more rotational motion because of that plane. You're going to get motion in your transverse plane, but your transverse axes, but your plane is going to be slightly different. Okay. Okay, so next we have scapulohumeral rhythm. Okay, so this is basically describing the motion between the shoulder girdle and the shoulder joint. Okay, so this picture is slightly wrong, but no matter how hard I tried, could not find a picture that was actually correct on the internet. So disregard the picture, but it still gives you the information potential. Okay, so the first 30 degrees of elevation is going to occur only at the glenohumeral joint. Okay, so that's where it's going to be initiated. Whether you're moving into abduction or flexion, any type of elevation type movement, first 30 degrees is at the glenohumeral joint. Okay, after that first 30 degrees, there is then a 2-to-1 ratio. Okay, meaning that if we're doing abduction, for every 2 degrees of shoulder abduction, you get 1 degree of scapular upward rotation. Okay, so you have a 2-to-1 ratio for your glenohumeral joint motion versus your shoulder girdle motion. Okay, so all of this information conceptually together is known as your scapulohumeral rhythm. Okay. Yep.
What's wrong about the picture? Is it the 30 versus
So the 60. Okay, yeah. So right here. So it should be first 30 degrees is glenohumeral joint, then it's a 2-to-1 ratio after that 30 degrees. So you basically take 150 divided by 2, 75 degrees at each side. Okay. Okay, so next we're going to do a review of your joints here. Okay, so this picture is just an overview of the different joints. So we have your sternoclavicular joint in the middle, your acromioclavicular joint, your glenohumeral joint, and then the scapulothoracic joint. Okay, so we're going to go through these kind of one by one. So starting first with your sternoclavicular joint. Everybody point to your sternoclavicular joint. Okay, it's going to be right here, that articulation between your sternum and your clavicle, sternoclavicular joint. Okay, so this is going to be a synovial joint. Okay, and it is very important because this joint actually forms the only direct attachment between the upper extremity and the trunk. Okay, make sure you remember that. Okay, so this one is a little bit confusing. We have it described here as a saddle joint, but there is actually a lot of debate as to what kind of joint this actually is. Okay, so depending on which reference text you look at, some describe it as more of a ball and socket joint, a double gliding joint, a plain joint, an incongruent saddle joint. So again, there's just a lot of debate as to what type of joint it truly is. And that really makes things confusing when it comes to our arthrokinematics. Okay, so regardless, there is consensus that this is a triaxial joint. Okay, what is triaxial?
It's going all
3 degrees of freedom. What is 3 degrees of freedom? Movement in 3 planes and 3 axes. Okay? So despite that, the movement that occurs here is very minimal. Okay? So this is not going to be something that is, very obvious, like when we're moving our shoulder joint. But despite that, you still get motion in all 3 planes and all 3 axes. Okay? So if we look at the motions here, they are going to be described relative to the position of the clavicle. Okay? So your sternoclavicular motions, we'll pretend this is our clavicle, are going to be elevation and depression. Okay? When you do this, you're going to basically have one side that is fixed. Okay? So this is going to look like your shoulder abduction and adduction. Okay? So elevation, depression. So this is going to occur in the frontal plane around a sagittal axis. Okay? Next we have protraction, retraction. Okay? So here, this is going to look more like shoulder horizontal abduction, adduction. Okay? So this is going to occur in the horizontal plane around a vertical axis. Protraction, retraction. Okay? Then we also have rotation. Okay, so we're going to have an anterior rotation and a posterior rotation of a clavicle. So this is going to look kind of like your flexion extension. So therefore it is going to occur in the sagittal plane around a frontal axis. Okay. All right, so we have a joint capsule here since it's a synovial joint. Bless you. And this is going to be reinforced by your ligaments. Okay, so we have anterior and posterior sternoclavicular ligaments. Okay, you have 3 major ligaments for this joint: your sternoclavicular ligaments, your costoclavicular ligament, and your interclavicular ligament. Okay, and then there's actually an articular disc that sits right between your articulating bones. Okay. The disc has 2 different components. Okay, it has an upper part and it has a lower part. The upper part of the disc is going to be attached to the posterior superior part of the clavicle. Okay, while your lower part is going to be attached to the manubrium. Okay, and your first costal cartilage. What's your costal cartilage? Cartilage between the ribs. Okay, so because the disc has these 2 different components, it almost acts like a double hinge on a door. Okay, so it can go either direction. Or a door that swings both directions. Okay, so again, 3 ligaments and a disc at this joint. Okay, so let's go back to your ligaments. As you guys start to learn the ligaments, again, this is building on your foundational information from Bio 150. We did not cover the ligaments in Bio 150, so again, this is a step up. So as you learn the ligaments, you need to know their names, where they attach, okay, what bones are we attached to, and then what do they do? Okay, so for ligaments, they are often going to restrict some type of motion. So you need to understand what motion they're restricting. Okay, so as you're studying these things, that's how you need to look at it. Okay, so let's start first with your sternoclavicular ligament. Okay, we have these color-coded on that right picture there. So here, this is an anterior view. So your anterior sternoclavicular ligament is the one that's in the red and orange color. Okay, so this is going to connect from the clavicle to the sternum. And again, like I said, we have both an anterior and a posterior ligament. So it connects from the clavicle to the sternum on both the anterior and the posterior aspects of the joint. Okay? So because of its position, that means it's going to restrict either anterior or posterior movement of the clavicle. Okay? So your posterior portion is going to limit posterior movement during protraction. Okay? The anterior portion is going to prevent anterior motion during retraction. is going to restrict excessive posterior movement when you are moving into protraction. Okay? The anterior sternoclavicular ligament is going to limit excessive anterior motion as you're moving into retraction. Okay? Another way that you guys can study this is in the labs when you're looking at the skeletons, using some type of fabric, whether it's, you know, you could use rubber bands or a TheraBand or rope or whatever it is that you have to actually put the fabric or whatever it is that you have in the location on the actual skeletons, and then do the motion. So you can see what would happen to that as you do certain motions. Okay? So try to come up with creative ways like that to really be able to visualize what is happening at the level of the ligament when you do certain motions. Okay, next we have your costoclavicular ligament. So in the picture, this is the green one. Okay, this is going to be a shorter, more flat, rhomboid shaped ligament. Okay, it is going to connect to the inferior surface of the clavicle, okay, and go to the superior surface of the costal cartilage, okay, of your first rib. That's where we're at. So because it's sitting between the clavicle and the costal cartilage of the first rib, it is going to restrict excessive elevation of the clavicle. Okay, so it's holding it right there in place. It's not letting it go too far up. Okay, lastly, we have your interclavicular ligament. That's the yellow one in this photo. So this is going to sit right on the top of the manubrium, and it's going to connect the two ends of the clavicles, okay, left and right clavicle. So because of its position here, this is going to work to restrict excess depression of the clavicle.
Can you say that again?
So your interclavicular ligament is this yellow one in the photo. It sits right in the manubrium, and it connects the two ends of the clavicles, okay, left and right clavicle together. Its job is to limit excessive depression of the clavicles. Okay, so now moving into your arthrokinematics. Okay, again, this is going to be slightly different depending on which text you look at. Okay, so I want you guys to remember it for now as written on this slide. That's what we'll use, but know that there is some discrepancy on it. Okay, so your manubrium is going to be concave, and the medial end of your clavicle is going to be convex. Okay, so if we are moving, your clavicle is going to be moving on your manubrium, making it a convex on concave articulation. Okay, so we know that's going to mean what in terms of your glide? Glide is going to occur in the opposite direction as the distal end of the moving bone. Okay, so when it comes to scapular elevation, okay, scapular elevation, the lateral end of the clavicle is going to move superiorly. So your glide is going to move inferiorly. Okay? Now, we are going to add in rolls. Okay, last week we basically only talked about your glide. Now we're going to add in a roll. Okay? This is going to follow your same basic rule. So if we have convex on concave, and we know our glide is occurring in the opposite direction, for your roll is also going to occur opposite, but it's going to be opposite of your glide. Okay? Versus if we were to have a concave on convex relationship, concave, we know the glide occurs in the same direction. That would mean our roll would occur in the same direction as the glide. Okay? So when you're talking about your rules, Your glide is always in reference to the distal end of the moving bone. Your roll is going to be in reference to your glide. Any questions on that? Yeah.
Did you see the roll is opposite?
For convex on concave, your roll would occur opposite the direction of your glide. For concave on convex, your roll occurs in the same direction as your glide.
So the same A and same.
Yes.
roll applies.
Yep, exactly. That part doesn't change. Just what you're referencing. Okay, so one more time, right here, scapular elevation. If your clavicle is moving in scapular elevation, we know the lateral end is going to move superiorly, so your glide is going to occur inferiorly. Okay, so if that was the case, what direction would your roll occur? Superiorly. Okay, lateral end superior, glide inferior, roll superior. So that's your arthrokinematics for scapular elevation at the sternoclavicular joint. Okay. Now if we move into scapular depression, it's going to be the exact opposite. So right here, this is my clavicle, scapular depression. So what direction is my lateral end moving? Say it.
Inferior.
Inferiorly. What direction is my glide?
Superior.
What direction is my roll?
Inferior.
Inferior.
So actually the roll is going directly with the end of the bone
Correct.
direction.
But you just don't get confused
Okay.
when you're thinking like that. That's always how I remembered it in school. But I didn't understand it, but I remembered the roll was the same direction.
Yeah.
Does the clavicle roll no matter what it's doing?
So, yes, you're always going to have a roll that's associated with your glides at the clavicle.
And the clavicle is always moving, say the other part that's attached to is moving, it has to, right? I mean,
Say that again.
if there's movement at the glenohumeral joint, is there always
Yes.
movement at the?
Exactly. So your clavicle's not just going to move in isolation, right? It's always going to occur in conjunction with your glenohumeral joint motions.
And scapular motions too, or
Yes.
really, because it's all.
It's all
attached.
connected. Okay, so now, those ones are pretty straightforward and firm across the board. Okay, where things get a little different here is going to be your scapular protraction and retraction. Okay, even if you look in your own textbook, it is written differently in the paragraph than it is described in your chart in your textbook. Okay, so some sources are going to describe your protraction retraction as convex on concave versus others describe it as concave on convex. Okay, because depending on what type of joint it is, it's going to dictate what the ends of the bone look like. Okay, so again, for now, let's just memorize it based on how I have it written on the slide, but no, this may or may not actually be true. Okay, so for protraction, theoretically, the distal end of the clavicle is going to move anteriorly, and if it was convex on concave, then your glide would be posterior, your roll would be posterior. Okay, and then opposite for retraction, where you would have an anterior glide and a posterior roll. Okay. With upward and downward rotation here, you basically are just going to get a spinning motion at the sternoclavicular joint. Okay, so the clavicle is mostly going to stay in place. It's just going to rotate as you're getting motion at these other points. Okay, so that brings us to our acromioclavicular joint. So here, this is going to connect your acromion process of the scapula and the lateral end of the clavicle. This is going to be a plain synovial joint, okay, meaning that it's just going to allow for a gliding motion, okay, in order to assist at the motion occurring at the sternoclavicular joint. So we have 4 ligaments here. You have 2 acromioclavicular ligaments, okay, so you have a superior acromioclavicular ligament and an inferior acromioclavicular ligament. Your superior portion is going to connect the superior portion of the clavicle to the superior portion of the acromion. Okay, so it is going to reinforce the superior capsule at this joint. Okay. Your inferior acromioclavicular ligament, this is going to be your inferior portion. So it connects the inferior portion of the clavicle to the inferior aspect of the acromion. Okay, just as the name implies. So therefore, because of that position, it's going to reinforce the inferior portion of the capsule.
There are posterior and anterior, or
Sorry?
there are posterior and anterior, inferior.
Nope, you just have superior and inferior here. Okay? So basically, these joints just help to hold the acromion process to the clavicle. Okay? So really, they are helping to prevent any type of dislocation of the clavicle. Okay? All right, so we also have your coracoclavicular ligaments. Okay, so if you look at the picture right here, this was your acromioclavicular ligament, right over top and bottom of your acromioclavicular joint. And then right here we have the coracoclavicular ligaments. Okay, so for these ones, these are going to connect your clavicle to your coracoid. Okay, so you have the lateral end of the clavicle and your coracoid, which is going to be on the scapula. Okay, so you're holding the clavicle to the scapula with these ligaments. So together, collectively, they are going to help prevent excessive motion of the clavicle moving posteriorly. Okay, so helping to prevent posterior displacement of the clavicle. Okay, that's its most important job. It also helps to restrict excessive rotation of the scapula.
Sorry, that's last one. In the coracoclavicular ligaments, you have to learn the coronoid and trapezoid first?
Yes, so they each have their own names. You have the conoid and the trapezoid ligaments. Collectively, they are your coracoclavicular ligaments. That's the same thing. Okay. We also have the coracoacromial ligament. So that is this one right here. That's attaching your acromion to the coracoid. Okay, so again, acromion to coracoid, these are both going to be portions of the scapula. And this one actually helps to form a roof over top of the humerus. Okay, so this is really important because it helps to prevent excessive superior humeral head translation.
Can you repeat that?
What, is that?
I said, can you repeat that last thing?
Yep, so your coracoacromial ligament, right here, this runs between the acromion and the coracoid of the scapula. And its job, as you can see, it helps to create a roof over top of the humerus. Okay, so it helps to prevent excess humeral head translation. Okay, and we'll dive more into this later on, but this is important because when you get that excessive superior humeral head translation, that's when you get shoulder impingement, which is a really big diagnosis that you will see very frequently. Okay. All right, next we have your scapulothoracic articulation. Okay, this is not a true joint. Okay, because there's no direct union between your bones. Okay, and there's no joint capsule. So really, your scapula is just sitting right on top of the rib cage and has no true direct connection. Okay? So in terms of your convex and concave, the anterior surface of the scapula is going to be, slightly more concave versus the posterior portion will be slightly convex. Okay? But despite this, we really don't have your typical concave convex rules that apply to this joint. Okay? In terms of the stability here, your stability is really going to come more through the clavicle, how we already talked about the clavicle, as well as the surrounding musculature. Okay? So any motion that you get here is going to be more a result of what's happening at your sternoclavicular and your acromioclavicular joints. All right, so back to your whiteboards. I know that was a lot of terms, a lot of ligaments. So I want you guys to draw a picture of these joints to the best of your abilities, but more importantly, draw the ligaments, okay? See the ligaments attached, and then write, you can use words for this one, write what those ligaments restrict. So what is their job? Move on to muscles, but this is going to be very brief, okay? So in regard to your muscles, you are expected to know the origin, insertion, actions, and nerve for every single muscle, okay? So get your flashcards out, use your textbook, write about 1,000,000 times, whatever you have to do to make sure you memorize these. I am not going to just sit here and read through them all, okay? Especially with the time constraints of this class that we now have, that's what's going. So as you guys are reviewing these and learning them, if you have additional questions about them, come see me and we can talk about them, okay? But again, you have to know these. You're gonna be quizzed on them, you're gonna be tested on them, okay? So we're just gonna go through kind of as groups, which ones do your big actions, okay? So for your scapula muscles in specific, your scapular retractors, these are going to include your trapezius muscles, okay, so you have 3 of them, upper trap, middle trap, and lower trap, as well as your rhomboids, okay? Your scapular protractors, this is going to include serratus anterior and pectoralis minor, okay? Serratus anterior has this name because of its serrated-like shape, okay? And make sure you understand in terms of orientation how this is actually sitting in relation to the scapula, okay? I know this isn't a very good image to be able to see, but right here, this is going to be the anterior border of your scapula, and serratus anterior is going to sit more on that anterior border, okay? For pectoralis minor, okay, this only is going to, well, it contributes to scapular protraction, but also scapular tilt as well, okay? So that's going to be the biggest place that you'll see this in is if somebody has, let's say, excessively rounded shoulders and forward head posturing, pectoralis minor is going to become short and tight, okay? That's mostly when you're gonna intervene at this muscle. Otherwise, you don't talk about it too much. Okay? For scapular elevation, okay, you have your upper trap, levator scap, and rhomboids. Make sure as you're studying these things, you're differentiating your upper, middle, and lower trap. Each portion has different components of its actions. Okay, so don't forget about that part. Your scapular depressors, lower trap, pec minor, and then like we said a minute ago, this also contributes to scapular tilt. And then scapular upward rotation, serratus anterior. This is a better picture of your serratus anterior. You can see how it comes more on the anterior border of the actual scapula. So it's not sitting posterior. So scapular upward rotator, serratus anterior, upper trap, middle trap, lower trap. All of those work together in order to perform scapular upward rotation. Okay? We also have downward rotation. I would say of all of the actions for the scapula, this seems to be the one that people have the hardest time visualizing. So make sure you really understand which muscles contribute to downward rotation, okay? This is gonna include your rhomboids, levator scap, and pectoralis minor, okay? I think it's because of the attachments, so make sure as you're learning the muscles, as you're considering their actions, you look at the origin insertion and figure out, okay, if this muscle contracts, if this muscle shortens, how is it going to affect the scapula? So even if you don't have these things memorized, if you're not a good memorizer, like try to reason through it in your head based on its attachments, okay? And this is one I would really make sure that you're able to visualize that motion because people do get confused with it, okay? I know that was really quick. So on your boards, boards out, boards and markers. Definitely use your boards for this one, so you're gonna hold up your answers so I can see them. Okay, right big enough that I can see them. That's okay. Help you remember more. Okay, without looking at your notes, without looking at your computer, which muscles elevate the scapula? And don't look at each other's boards. No cheating. If you don't know, right, you don't know. Mm-hmm. Scapular elevation. Okay, Kent, you have 3.
Oh.
Hold them up when you're done.
Do it.
We haven't talked about supraspinatus yet. Is everybody done? All right, let's see all of them. Okay, so you come down. Most of you got upper trap. Okay, it's upper. We know it's going to elevate. Okay, levator scap. Same thing. Think about the name. Levator, elevate. Okay. Third one is going to be your rhomboids. Okay, so again, if you go back to that picture, you can see how if it contracts, it's going to pull it up. Okay. A lot of people wrote lower trap. Okay, now you can't really see the scapula in this image, but for lower trap, again, if this contracts, if it shortens, it's going to pull the scapula down. Okay, so again, even if you don't have these actions memorized, think about where it's sitting and what's going to happen when you contract. Okay? Oh, well, I just gave you the answer to the next one. Which muscles depress the scapula? You have 2. What is the top right there?
Does the little.
All right, it looks like mostly everybody got it. We have the lower trap, like we just talked about, as well as pec minor. Nice job. Pec minor depressant. All right, next one. Which muscles are your upward rotators? We got 4 here. Four. Think we talked about this with your force couples last week. Remember, this forms a force couple.
I'm not looking.
You said there was
4.
Can you read that? That's fine.
You're missing 2 there. But those are right. we have all three traps, upper trap, middle trap, lower trap, as well as what? Serratus anterior. So all four of those are going to work together to perform upward rotation of the scapula. All right, next, what are your downward rotators? We have three.
Yeah.
That one's right. All right, so the three are, what are they?
Rhomboids,
Rhomboids,
pec minor,
pec minor, levator scap. That was the hardest one so far.
I'm just like in my brain doesn't seem like it tracks. I'm like, what is it? It does. Like it does.
No, it's because of the when you're
Watch that
when it shortens, it's going to cause that rotation downward.
because it's like it just doesn't. It doesn't.
All right, two more. What are your scapular retractors? Go ahead and just do protractors while we're at it.
Retractors and
Both
protractors.
of them. Make a line.
Upper middle layer, middle layer, and rhomboid, right? And then rhomboid. Or retractor. It's an upper middle layer. It's upper middle for retraction. And then
What are we looking for? So we have 2 for protractors and 4 for retractors. I was gonna say you're missing one. Yeah, you're just missing one.
segments, right?
Yep.
In the middle of the writing. You're like, wait.
All right, nice job, guys. So what are your protractors? Serratus anterior and pec minor. All right, and then your retractors,
Upper, middle, lower, and rhomboid.
all your traps and your rhomboids. Nice job. Okay, so a good little refresher, but you guys are gonna have to spend some time with it, okay? But make sure as you're studying, you're also able to group them like that, okay? What are your commonalities for your origins? What are your commonalities for your insertions, the actions, as well as the neural innervations, okay? All right, so again, just a smidge of application here. We're not going to go very in depth. We're going to build all this as you go through your next couple semesters, but just to start getting you thinking about some of these concepts. So we talked about force couples last week. Somebody remind me what a force couple is. That's exactly correct. So we are going to get a rotation here. So these are your 2 big force couples when it comes to the scapula and the muscles here. So in order to create what motion, the upper trap, the lower trap, and serratus anterior are going to contract together. So what motion are those going to perform? Upward rotation. So you have these 3 forces acting in different directions. that's going to cause that rotational moment at the scapula. Okay? You have the same thing for downward rotation. For downward rotation, you have your levator scap, your rhomboids, and your pec minor. So all three of those muscles are going to contract together and cause that downward rotation to occur at the scapula. Okay? Okay, we also have to consider posturing. Okay? All of the muscles that we've talked about are going to affect posture in some way when it comes to muscles that are shortened or muscles that are lengthened. Okay? So as you guys are starting to learn your muscles, learn their actions, have all those things memorized, I want you to start thinking about what would happen if these muscles were impaired. Okay? In any kind of way. Okay, if your pec minor is tight, like we talked about earlier, that's going to force you into this position, right? Where you're in protraction, you're rounded. That's what it would look like if pec minor was tight. Okay? If your anterior musculature is tight, that means that your posterior musculature is going to be overly lengthened. Okay? Usually, not always, but usually when something is lengthened, it is weak. When something is shortened, it is tight and it is strong. Okay? So with all of these different muscles, as you're learning the actions, try to visualize what it would look like if that muscle was excessively short or if that muscle was excessively lengthened. Okay? Does that make sense just conceptually? Good. So again, we're not going to dive super far into this. This is the most common thing that you will see. So in that forward head rounded shoulder posture, you're going to have tight pecs, tight sternocleidomastoid, tight upper trap and levator scap, and then everything in opposition to those is going to be either weak or lengthened. So your lower trap, more your retractors, as well as your deep neck flexors. Okay? So next semester in assessment, we will go through how to perform an appropriate postural assessment and learn how to identify all of these, short and or lengthened muscles. Okay? And then again, apply that even more once we get to orthopedics. But for now, I just want you to start thinking about it as you're learning the actions. Okay?
We all just sit up straight while you're
Exactly. Yeah, I saw a big rise in height there. Okay, so this is in this section of your book. Again, we will dive much further into this when it comes to orthopedics next summer. But for now, I just want you to start understanding what this will look like. So this, you just have two pathologies here to start thinking of. So this one is an acromioclavicular joint separation. Okay? Your clavicular joint can be very easily sprained with trauma. Okay? Your most common mechanism of injury that you're going to see with this is a Fuchs injury. Who knows what Fuchs stands for?
Did it fall on outstretched hand?
Yep, so fall on an outstretched hand. Write that down because you're going to hear it a million times in the next year. Okay? Fuchs, fall on an outstretched hand. Okay, that's your most common mechanism of injury here. It can also occur through a blow, a direct blow to the lateral shoulder. Okay? So the grades of your injury here are named by the involvement of the ligaments, okay, which we learned earlier, so you can use this as your application for those ligaments, okay? So your top row here, your first 3 grades of injury are going to be your most common, okay? Grade 1 is just going to be a strain, okay? So your acromioclavicular ligament is still intact, it's just slightly stretched. Okay, those are your blue ligaments up there. Orange. Grade 2, your acromioclavicular ligament is ruptured, but your coracoclavicular ligament is still intact. Okay? Again, there it's just going to be slightly stretched. So you can see in this image right here, this ligament's going to be torn, these are stretched. Versus here, everything is still intact. All right. And then in grade 3, all three of these ligaments are gonna be torn. Okay, so both your acromioclavicular and your coracoclavicular ligaments, all three are torn. Okay, so again, for now, learn your ligaments, know where they're at, and then what grade 1, 2, and 3 are. And we'll stop there with this for now. We also have a winging scapula. So this picture depicts what a winging scapula is. Okay? So this again is going to be part of just your general postural assessment. Okay? And the winging scapula, this is indicated when the medial border of the scapula comes off of the rib cage. Okay? So what muscle is going to hold your scapula against your rib cage? Serratus anterior. Okay? This is a very common board question, to make sure you understand this. So again, serratus anterior is going to hold that scapula against the rib cage. So if there is the presence of a winging scapula, that is going to indicate weakness in the serratus anterior. Okay? It could be muscular weakness, or it could be a nerve injury. Okay? What nerve innervates serratus anterior? The long thoracic nerve. Okay, so if long thoracic nerve is compressed or injured in any way, that can also result in a winging scapula. Okay, so we're just going to take 5 minutes. Again, I do not expect you to be experts at this, but I want you to find somebody who you haven't worked with much yet, and just try to give a general, and then we'll continue through it next week. Okay? So this is already posted on Blackboard, so you should be able to see it. This is going to be chapter 13 in your book. So again, just some objectives. Again, review your bony osteology, review your key bony landmarks and your soft tissue structures. We're going to really dive into your arthrokinematics for this section. Same thing with your muscles. Make sure you know your origin, insertion, actions, and nerve for every single muscle we go through. Draw the brachial plexus. So we are going to introduce that concept with this unit. You're going to learn how to draw it. You're going to understand what it means. And then as indicated in one of the letters from your bigs, make sure you know it. Okay? I'm going to tell you that 12 times. So make sure you learn it. And then again, we're going to apply this information more in reference to nerve injuries for this section. Okay? So this one is going to be a lot more focused on the nerves and understanding how that works with everything else that we talked about. Okay? So again, table of contents here, we're going to review your bones, your ligaments, your joints, your muscles, and then we're going to apply that information. So starting first with your bony anatomy, again, I'm not going super deep here, but make sure you know what landmarks are associated with your origins and your insertions. Okay? So if we look, we have your humerus head, that's a more direct view of your humerus on that side. So your head, you have your anatomical neck. Right here, you have your intertubercular groove, which is the same thing as your bicipital groove. Those terms are interchangeable. Your greater tubercle and your lesser tubercle. So if this is an anterior view of the humerus, is your greater tubercle more lateral or more medial? Say it louder. More lateral. Okay? Again, that is a common landmark that people confuse. So make sure you know greater tubercle is more lateral, lesser tubercle is more medial, and your intertubercular or bicipital groove sits right in the middle of them. Okay? You have your deltoid tuberosity right here. That's going to be your attachment for the deltoid muscle. And then we'll go over more of the elbow landmarks in the elbow unit or module next week. Okay? So again, if you're looking here, this one is a little bit more color-coded for you so you can really see that anatomical neck as well as your greater and lesser tubercles. All right, so we have your glenohumeral joint. What is the articulation for your glenohumeral joint? What is it? Glenoid fossa and the head of the humerus. Okay? When I ask a question, speak up, guys. Be confident in your answers. Okay? You joint is it? Ball and socket. Is it uniaxial, biaxial, or triaxial? Triaxial, which means what? 3 planes, 3 axes. All right, somebody tell me what the frontal plane is.
Plane divides your body from posterior to anterior.
Okay, what motions occur in your frontal plane? Abduction, adduction. Forgot about the scapula. We're back to normal now, okay? All right, sagittal plane. Left and right, what motions? Flexion, extension. Transverse plane. What motions? Okay, a little disorganized, but I think we got it. Okay. Yes, exactly. All right, so the shoulder is going to be one of the most movable joints in the body, okay? It is going to be one of the least stable, okay? All of your stability, you get some stability from your articulation, but very little, okay? Most of the stability is going to come from the surrounding soft tissue structures. So not a lot of bony stability here, but your ligaments, your muscles, that's really what's going to hold it in place, okay? So when I say soft tissue structure specific for glenohumeral joint, that's going to include your labrum, the joint capsule, and then, like we said, all of those surrounding muscles. Okay? For your joint capsule, this is going to be a very, thin-walled structure. Okay? So it is going to attach kind of around the rim of the glenoid fossa, of the scapula, and then the anatomical neck of the humerus. So that's kind of where it sits. This is going to be formed by a more fibrous outer membrane and then an inner synovial membrane. So we know it's a synovial joint, so it's going to have that synovial fluid on the inside to help lubricate the joint. Okay? So you have 4 different portions of this capsule. All right, there's anterior, posterior, superior, and inferior portions of the capsule. Okay, so it's kind of encompassed by the whole thing. If your arm is just hanging by its side, okay, the superior portion of the capsule is going to be taut, T-A-U-T, taut, tight, okay? The inferior portion is going to be on slack, okay? The arm is just hanging by your side. That is going to switch when you go into shoulder abduction. When I lift into abduction, the superior portion will become slack, the inferior portion will become taut. Okay? That will change depending on the orientation of your arm. For the anterior and posterior portions, this is going to change with your rotational motions. Okay? So if I'm going into shoulder external rotation, the anterior portion of the capsule will become taut, versus if I'm going into internal rotation, the posterior portion of the capsule will be taut. Okay? All right, next we have your glenoid labrum. Okay, this is going to be a fibrous ring that surrounds the rim of the glenoid fossa. Its main function here is to deepen the articular cavity. Okay, so we know your glenoid does not have very much space. Okay, so this helps to solve that issue and allow for greater contact with the humeral head. Okay, this is your structure that is going to be most frequently damaged when it comes to shoulder instability. Okay, you're often going to see labral tears. There are a lot of different types of labral tears. Okay, again, we'll go more deeply into that when we get to orthopedics, so I don't need you to understand all the ins and outs of it now. The one that you will most commonly hear is a slap tear. Okay, have you heard that term before? Slap. Okay, SLAP stands for superior labrum, anterior posterior. So anterior posterior just indicates the direction of the tear. So a labral SLAP tear, superior labrum, anterior posterior. Anterior to posterior indicates the direction of the tear in the labrum. Okay, so it's torn from front to back. Okay, this is what you see most often in baseball players. Okay, very common injury there. Okay, so with that, your common mechanism of injury is going to occur through forceful flexion and internal rotation. So if you think about throwing baseball, the follow through action. So that deceleration is often where you're going to get a slap tear. Okay? It could also happen in other ways. If you're lifting something heavy, if you have a traction type injury, a foosh, which stands for what? Fall on an outstretched hand. So it can occur from several different things. Okay? So for now, understand the terminology and how it relates to your anatomy for the labor. Okay?
Say what again, that forceful motion was on the ball?
So it's flexion and internal rotation is the position, but it's more the deceleration. That's the mechanism of injury. All right, so that brings us to your ligaments for the glenohumeral joint. Okay, these ones are easy to remember because they're basically just called the glenohumeral joint ligaments. Okay, so you have three. You have a superior, a middle, and an inferior glenohumeral joint ligament. Okay, the purpose of these ligaments is to help reinforce that capsule. Okay, so they each have different responsibilities dependent on the different angles of your osteokinetic movements. So this, I'm going to go a little bit more specific than is written in your book, so make sure you write this part down. Okay, so your superior glenohumeral joint ligament will limit adduction and external rotation. External rotation when the shoulder is in 0 to 45 degrees of abduction. Okay, so again, superior glenohumeral joint ligament will limit shoulder adduction as well as external rotation when the shoulder is in 0 to 45 degrees of abduction. One more time. Superior glenohumeral joint ligament limits shoulder adduction as well as external rotation when the shoulder is in 0 to 45 degrees of abduction. AD.
Okay, but the first one was AD?
Yes.
Okay.
Okay, one more time. Superior glenohumeral joint ligament limits shoulder adduction, AD, shoulder adduction. It also limits shoulder external rotation when the shoulder is in 0 to 45 degrees of abduction. So when I'm right here, okay, 0 degrees to 45 degrees of shoulder abduction.
There's like
Zero.
screens. There's so many different screens.
0 to 45 degrees of shoulder abduction, it's going to limit external rotation. Exactly. So if that ligament was tight for whatever reason, it's scarred down post-operatively, I might be way tighter right here in external rotation than I am up here. If just my superior glenohumeral ligament is okay, so 0 to 45 degrees of shoulder abduction. Your middle glenohumeral joint ligament will limit shoulder external rotation between 45 degrees and 90 degrees of abduction. So now I'm up here, 45 degrees of abduction to 90 degrees of abduction. So in this space, the middle glenohumeral joint ligament is going to limit your external rotation. 45 degrees to 90 degrees of shoulder abduction.
Can you say that one more time?
Middle glenohumeral joint ligament is going to limit shoulder external rotation between 45 degrees and 90 degrees of shoulder abduction. Okay, and then your last one is your inferior glenohumeral joint ligament. And that is going to limit external rotation greater than 90 degrees of abduction. Okay, so any overhead motion going into external rotation is going to be most limited by inferior glenohumeral joint ligament. So again, inferior glenohumeral joint ligament is going to limit shoulder external rotation above 90 degrees of abduction. I feel like this just put us over the edge here. This is the final straw. Okay? Think about when I said back at the beginning, when the arm is down by the side, what is tight, what is lax? Right, superior is tight, inferior is lax. So that's going to change as you change your degrees of abduction. So you're basically just flipping this in reverse. When I'm down by my side, if I'm trying to go into external rotation, what ligament is going to be most limiting? Superior. Okay, because we know it's tight in that position. Okay, versus middle, going into external rotation, my middle ligament is going to be most restrictive. Versus when I'm up here, greater than 90 degrees, I'm going into external rotation. Well, now my inferior portion is missing. Okay? Anything I need to repeat again there? Or at least do you have it written so you can go back and reference it and study it? Good. Okay, so we also have several different bursa in the shoulder. Okay? So the biggest ones we're going to point out are subacromial and subdeltoid. But all of these little blue circles here are all different bursa. Okay? So your subdeltoid bursa is going to be very large and it's going to sit between the deltoid muscle and the joint capsule. Okay? So know that these are going to be present in areas of a lot of friction. Okay? You also have your subacromial bursa. That is this one right here. So you can see that one is also pretty large. And it sits right underneath the acromion. Okay? So you have your acromion and you have your coracoacromial ligament. Where does coracoacromial ligament sit? Between the coracoid process and the acromion. Okay? For a lot of these things, if you learn the names, you can probably infer where they attach to. Okay? So coracoacromial ligament between the coracoid and the acromion. So right underneath that, right underneath the acromion, you have your subacromial bursa. Subacromial beneath acromion. Okay? So these are important because these can turn into really big pain generators. Okay? Meaning they can be the true source of pain in someone who's coming in with shoulder pain. Okay? And this is not something where you can really directly intervene in terms of physical therapy. They could get a steroid shot, okay, that could go right into the bursa and help with pain there. But mostly, we're going to have to intervene at the surrounding structures to offload the bursa. Okay? So, for example, I mentioned impingement earlier, shoulder impingement, right? So, if I had really poor scapulohumeral rhythm, for example, I'm going to get excessive superior translation of my humeral head. So my humeral head is going to start butting against my acromion. Okay? When that happens, all of these soft tissue structures between the humeral head and the acromion are going to get pinched and compressed, and that's going to turn into pain. Okay? One of those soft tissue structures is your subacromial bursa. So humeral head translates superiorly, and it pinches the subacromial bursa between the humeral head and the acromion, and that causes pain. Okay? So the way we fix that is to normalize your scapulohumeral rhythm, strengthen the rotator cuff, make sure that the humeral head is, sitting in the position it's supposed to. Okay?
Is MRSA filled with the same kind of stuff that our spinal discs are? Are they similar or is it totally different?
You're going to have some of the same components, but it's going to be a different type of fluid. Like, that is more a gelatinous substance versus this is going to be like a more liquid type substance. If that makes sense. So think more, this would probably be more comparable to like a synovial. Yeah. Yeah, exactly. Okay, we also have our osteokinetic motions. Does everybody feel comfortable with those at this point for the shoulder? Any remaining questions for shoulder osteokinetic motions? Okay, so with these motions, like I talked about last week, there is a norm for each one, okay? You guys have to memorize the norms, okay? That's the goal for this class, and then next semester, we will learn how to actually measure them, okay? So, your norm's on the left-hand side here, or your right. For flexion is going to be 180 degrees. Extension is going to be 60. Abduction 180. Internal rotation 70. External rotation 90. Okay? Written up here, you can see how this says 0 to 180 degrees. That does not mean that anything between 0 and 180 is normal. Okay? It means 180 degrees is normal. Your starting point is 0. Okay, so if I'm going into shoulder flexion, I'm starting at 0 degrees of shoulder flexion. I'm going to 180 degrees of shoulder flexion. That is normal. Okay? Versus if somebody had some type of muscular contracture, let's say, and they can't bring their arm to shoulder to 0 degrees of shoulder flexion. If I'm starting here, that starting number would change when I document. So let's say I'm starting in 20 degrees of shoulder flexion, but I can still get to 180. You would document it as 20 to 180. Does that make sense? Okay, but otherwise, in documentation, you don't typically see that first number. Okay, oftentimes it will just be written, shoulder flexion, 180. When it's like that, you can assume that it started from 0. You would only see it documented as something other than 0 if they were not able to attain that 0 point. Okay, any questions on that? Okay, so on here we also have listed your open packed and closed packed position. Like I mentioned last week, you also have to remember what these positions are for each joint that you cover. Okay, so written here, your open packed position, 30 to 60 degrees of horizontal abduction and 30 to 60 degrees of shoulder flexion. Okay? Now, for this one specifically, this is stated differently depending on which textbook you use, but it means the same thing. Okay? So I want you to write down what I'm about to say. Okay? So your open pack position, according to your board test prep book, okay, is going to be 55 degrees of abduction and 30 degrees of horizontal abduction. Okay, so we're generally in the same area depending on which way you look at it, so that doesn't change it, but I do want you guys to understand the difference in terminology and memorize it like your board test prep book.
Can you say it in
55 degrees of abduction and 30 degrees of horizontal adduction. Everybody got it? Okay. For your closed pack position for the shoulder, this is going to be full abduction and external rotation. Okay, so you can do it like this, you can do it like this, doesn't matter which. Okay, the full abduction, external rotation, that's your closed pack position where the joint is going to really be locked down. Good? Does everybody feel comfortable with your planes and axes for the shoulder at this point? Good? Any remaining questions here? Okay. All right, so we also have what is called a capsular pattern, okay? This is a characteristic loss of motion when the capsule is tight, okay? So again, each joint that you guys go through, when you start reading the textbooks or you look at your board prep book, you're gonna have your open pack position, your closed pack position, and you'll have a capsular pattern. So again, capsular pattern just meaning this is a characteristic loss of motion at a specific joint when the capsule is involved. Okay, so being able to identify these patterns helps you as the clinician to understand when the capsule is involved and then how to intervene most appropriately. Okay, so when it comes to pathologies involving the capsular pattern, the shoulder is going to be the most common one that you see. So if you get a capsular pattern question on board, it's most likely going to be the shoulder. Okay, so for this, your capsular pattern at the shoulder is written like this: external rotation greater than abduction greater than internal rotation. Okay, so if the capsule is involved, this means that external rotation is going to be your greatest limitation in range of motion. Okay, followed by abduction, that's going to be your second most limited motion. Followed by internal rotation, that would be your third most limited motion. External rotation greater than abduction greater than internal rotation. External rotation is the greatest limitation in your range of motion, followed by abduction would be the second most limited, followed by internal rotation would be your third most limited. Okay, the pathology that you typically see this with in the shoulder is called adhesive capsulitis, okay, also called frozen shoulder. Okay, that is the most important application of this particular information. Okay, oftentimes you see adhesive capsulitis in patients who have additional comorbidities, most frequently diabetes and thyroid disorders. Alright, we are going to end with an activity today, okay? So I want you guys to break up into groups of 4 or 5.